Good afternoon, everyone, and welcome to this Science Café hosted by the Faculty of Science at Carleton University. My name is Michel Barbeau. I'm the director of the School of Computer Science within the Faculty of Science at Carleton University. And I will chair today's session. So your audio and video are muted. And if you have question, please click the Q&A button and type your question, and we will try to answer your question as quickly as possible. So I'm very pleased to introduce Dr. Holden. Dr. Holden is an assistant professor in the School of Computer Science at Carleton University. Previously, he was a postdoctoral fellow at the Malone Center for Engineering in Healthcare at the Johns Hopkins University. He completed a PhD and a master in computing at Queen's University, and he received a bachelor in applied mathematics and physics from Western University. His primary research interest is surgical data science. And Dr. Holden will present a talk today entitled Improving Patient Outcomes in Surgery Using Machine Learning. So thanks again for joining us. And I will hand it over to Dr. Holden for the presentation.
Thanks very much for the introduction and the invitation to be here. Let me just share my screen with the presentation here. So for today's presentation, what I'm going to talk about is how we can use data-driven approaches, including machine learning, to improve the outcomes or help doctors improve the outcomes of patients who are undergoing surgery, or more generally, interventional healthcare. And so this research falls under the field of what's called surgical data science. And I've pasted here the community definition of what surgical data science is. It aims to improve the quality of interventional healthcare and its value through capturing, organization, analysis, and modeling of data. And so two things that I really want to point out here. The first is that surgical data science is not just about surgery. It's about all types of interventional healthcare. This includes things like radiation therapy, diagnostic ultrasound, interventional gastroenterology, needle insertion, and other types of interventional healthcare. We simply use the word surgery because it is one of the most well-known examples of interventional healthcare. The second thing that I want to point out is this involves all components of the data pipeline. It is not simply about machine learning, but it's rather about including the capturing of data or collecting, how we can organize it, and how we can analyze and process it. And so the community vision for surgical data science looks something like the following. So whereas in the past we had fairly limited knowledge of medical interventions, of human anatomy, and we had fairly rudimentary tools to perform surgery, at present we actually have quite sophisticated knowledge. We know a lot about medicine. We know much about human pathology and anatomy. And for any individual patient, we may have considerable health records or medical history. And we also have quite sophisticated devices, medical imaging devices, robot assistants for certain types of surgery, and other very sophisticated surgical instruments. But the issue here is that the integration of the information the burden of doing this is still on our surgeon or our interventionalist. So they must understand all of the knowledge we have about the patient, their health, and the intervention, and use that understanding in order to effectuate the surgery using these devices. And this is really challenging for surgeons. And so the goal is to alleviate some of that burden that is placed on surgeon and use computer assistance and other data-driven approaches in order to facilitate this understanding of information for our surgeons and help them better effectuate the surgery using the devices that are available to them. And so this is the vision for surgical data science. And so the first thing that we might consider when we talk about surgical data science is what data or data sources are available to us. And so specifically, what I mean about this is what data is collected during the course of the intervention or the surgery. And then this data may be supplemented with things like medical history and domain knowledge about the anatomy and pathology. So what types of data might we collect during the intervention? Well, we can collect data like medical images. So we can think about traditional medical imaging modalities like CT, MRI, ultrasound, but we might also have other non-traditional types of medical images. For example, we might collect information from laparoscopic or other endoscopic videos. We might put a webcam in our operating room and monitor our procedure there. Other data we might collect includes navigation data. So in modern computer-assisted surgery, often we have some form of surgical navigation that helps surgeons direct their tools relative to the anatomy. This involves tracking the tools in anatomy. So if we can use this tracking or navigation data, this could facilitate understanding of our surgery as well. We might also monitor patient status data. So we can monitor, for example, their vital signs, their heart rate, their respiration rate. We can even monitor how their muscles are being affected by the surgery. As you can see in this example at the bottom here, we actually have an interventionalist who's manually monitoring a patient's muscle reaction to deep brain stimulation. We might also monitor the status of our surgeon, where they're looking, where they are in the operating room, perhaps how much they're sweating, how much they're concentrating, how much their muscles are moving, or what their muscle activity is. So together, there's very many and very diverse sources of data that we can collect during a surgery or during some sort of intervention in order to help us understand the intervention. And by understanding the intervention, we can facilitate the surgery or the intervention by providing information to our clinician or our doctor to help. And so in what ways can we apply this data? What ways can we use this data to improve interventional healthcare? And so before I go into the applications, I want to emphasize one particular thing, and that is the idea is not to replace surgeons in healthcare, but to assist them. So by providing them more information or other types of assistance or guidance. And so these are intended to augment and help doctors. So one of the main applications of surgical data science is in decision support. So if we can monitor data as a surgery ongoes, understand what is ongoing, so that is, have some sort of context awareness about what's ongoing during a surgery in real time at any point, then what we can do is we can, based on what's happened so far in a surgery, recommend to the surgeon the best course of action on how to optimize the patient outcome. So if everything's going well, we might recommend to the surgeon to proceed. If a tissue was damaged, we might recommend to repair the affected tissue. Or if something else has gone wrong, we might recommend a different surgical approach. Another example where we might have added value in healthcare is in a smart OR assistant. So if, again, we can understand what's going on during a surgery, we can help the surgeon to do the next step. So that is, for example, we could introduce a robotic scrub nurse that passes the right tool or instrument to the surgeon at the right time. Or we could introduce context-aware augmented reality. So that is, provide the right type of display of some sort of augmented reality image, depending on what the surgeon's doing and what will be most useful for that particular step of the intervention. We can do data-driven OR scheduling. So of course, time in the operating room is very expensive. But if we can monitor what's ongoing in the operating room and based on that, predict approximately how much time is left in our surgery, then we can know when to start prepping our next patient for surgery. This is going to minimize downtime in the operating room and also minimize the amount of time a patient is waiting idle between preparation and actually going into surgery. So if we can do this, we can save significant time and expense. The final example that I'll talk about is in computer-assisted training. And so in addition to using these methods and using this data to understand what's going on during a surgery, we can also use data to understand, likewise, what's going on during a simulated surgery in a simulation-based training situation. This way, what we can do is, if we can, based on the data we collect in a simulation setting, we can do things like provide real-time coaching, explaining to a trainee how to do the next step of an intervention. We can provide automated assessment. We can, based on the data we collect, tell the trainee how well they did, and perhaps even provide some sort of targeted feedback on how to improve each particular step of the intervention. And so together we can use this to build a computer-assisted training system. And so this is sort of a general overview of what goes on in the space of surgical data science. So I want to take the next portion of this discussion to talk about some of the ongoing work that we have. And this work primarily is related to that last application in training and assessment. And the primary source of data that we use is tool motion or surgical navigation data. So that is, we try to provide assessment and feedback to trainees based on motion of tools and instruments in a computer-assisted training environment. And one of the big sort of tenets of our research is that we wish to integrate domain knowledge into these data-driven approaches. So we don't simply wish to collect data from the operating room, naively apply some machine learning method and compute a result. We wish to somehow integrate domain knowledge from clinical experts into this pipeline. So one of the projects that we have ongoing is in context awareness in surgery. And so in order to achieve context awareness in surgery, one of the things that we need to do is we need to formally define surgery. And so this is going to allow us to do things like decision support, context-aware, augmented reality, and in the case of training and assessment, real-time coaching. But in order to do this, we need to define the surgery formally. And so to do this, we build what's called a surgical ontology. And effectively, what a surgical ontology is it is a list of all of the components and elements involved in a surgery. So in particular, the most important components or elements in a surgery include the possible actions, things like moving a tool, inserting a tool, the instruments, so things like forceps or perhaps a needle or a scalpel, and anatomy. So, of course, things like the diverticulum or a hernia. And so if we can define all of these elements and components within a surgery, then we can speak about these elements and components formally. And so typically what we do is we define a tuple consisting of one action, one instrument, and one anatomy as a so-called activity. And these activities are what make up the fundamental building blocks of a surgery. And we can use these activities to build up what we call a surgical process model. And so what a surgical process model is it's a list of all possible activities that can ongo during a surgery and the possible transitions as well as their probabilities. So in this example, I've illustrated a very simple surgical process model for a needle insertion. So in this case, we might include activities like translating the tip of the needle to the skin, rotating the needle to the correct direction, inserting the needle through the ligamentum flavum into the epidural space, etc., etc. And so if we have a list of all possible activities in a surgery, as well as their transitions and those probabilities, this is what we consider a surgical process model. And so how can we use a surgical process model to help us achieve context awareness during a surgery? And so effectively what we do is we use the following type of pipeline. So again, as I say, I'm primarily interested in tool motion or tool kinematics data. So what we try to do is we try to somehow encode our tool kinematics data, which is effectively a time series that we collect over the course of an intervention. So we try to encode this time series as a vector or some sort of symbolic representation. Then once we have this encoding of our tool motion, we can combine our surgical process model with some sort of state transition model in order to predict an activity based on the sequence of representations that we observe throughout an intervention. So for example, the way that we do this in practice is we encode our tool kinematics data into a vector representation using a recurrent neural network. And then given the representation, we build a state transition model based on the surgical process model. And then based on the representation and that state transition model, we can predict the most likely ongoing activity. And so if we can predict the ongoing activity, effectively that means we know the context of what's going on. That is, we know what's going on at any point in time. And so we've done this in the case of spinal needle insertions, so both in ultrasound-guided epidurals as well as in lumbar puncture, and we're able to achieve context recognition with accuracies of approximately 80% at any given time. And so we can use this in real time to identify what's going on during these interventions. The second avenue of ongoing work that I want to talk about is in skills assessment. So this is related to the ongoing shift throughout Canada to a competency-based model of medical education. And so what that means is that we want to be able to monitor trainees' learning curves as they progress through a training curriculum. And we want them to graduate based not on how much time they've been training, but rather based on how competent they are. So in order to do this, we need to be able to measure competency. But it's very time consuming for experts to do this. So instead, what we try to do is we try to do automated skills assessment based on data we collect in the simulation environment. And so the traditional approach to do this is to consult with expert clinicians and try to derive a set of performance measures or summary statistics that, in their opinion, are good measures of skill. So traditionally, we employ summary statistics like completion time, like how much the hands or the instruments are moving, how much that's affecting the tissue, or perhaps in the case of ultrasound, how many points of interest we've scanned. And so this has worked quite well traditionally. And so one of the things that we can do is we want to be able to say what aspects or what facets of skill do each of these summary statistics measure. And so what we've done is we've developed a method based on exploratory factor analysis that groups these summary statistics or performance metrics based on how redundant or how much they depend on each other. And based on these groupings, we can, using our clinical knowledge, identify what aspects of skill each of these summary statistics assess. And so what we find is that different summary statistics assess different aspects of skill, but there is a lot of redundancy amongst our summary statistics. But perhaps more alarmingly, what we also realize is that our summary statistics do not provide a complete assessment of skill. And so the more modern approach that we employ is to do skills assessment using some sort of deep neural network. The advantage here is that the neural network will implicitly learn summary statistics or analogs to summary statistics that may cover aspects of skill that are not assessed by those manually derived summary statistics from our clinical knowledge. So recent work in skills assessment, what we do is we employ temporal convolutional networks in order to assess skill. But these temporal convolutional networks, although they find some aspects of skill that aren't measured by our summary statistics, what we find provides added value is if we actually integrate that domain knowledge or integrate those summary statistics into our networks. Then we can both assess those trainees in terms of those summary statistics, as well as based on those variables or based on those analogs to summary statistics that we cannot manually derive. And so we've been doing this in the case of diagnostic cardiac ultrasound, where we monitor the motion of an ultrasound probe during these cardiac ultrasounds performed on real patients. And we are able to assess skill with accuracies upwards of 90%. And so this is currently being employed or tested in a simulation-based training curriculum for diagnostic cardiac ultrasound. The final avenue of work that I want to talk about is in multi-perspective context awareness. So in the previous work where we talked about context awareness, we only talked really about context in one sense. We talked about sequential context. So what activities follow which activities in what order. But really, we're missing part of the picture. Although we can understand the sequence of activities that are ongoing, in order to fully understand context, we also need to understand how these activities affect the anatomy and affect the pathology. So how does this activity change the patient's anatomy or treat the patient's pathology? So one application where we're working on this problem is in septoplasty surgery. So effectively, what we want to do is we want to, based on the actions or activities performed in the septoplasty surgery, come up with a model of our septum. So septoplasty surgery is a surgery where we wish to correct the deviated septum, the septum being the cartilage between the two sides of the nose, separating them. So septoplasty surgery aims to correct this deviation. But in order to correct the deviation, we need to have some model of what the septum looks like. So what we aim to do in this work is, based on instrument data that we collect during the septoplasty surgery, continually update our model of the septum as we collect more data and as the septum is operated on, so that we have that knowledge of how the anatomy is being affected by our surgery. And so this is going to provide another avenue for context. And so we've been able to do this in septoplasty surgery, reliably reconstructing the septum based on the tool data that we collect in the operating room. And so we're able to reconstruct the septum with errors under 3 millimeters. And so this is intended to have application in skills assessment for septoplasty surgery, as well as facilitating surgical navigation, since we can reconstruct the septum in real time and how it's modified by the surgery. We can use this to help navigate our tools during the surgery. So these are 3 avenues of work that we're working on, but they all have some common ongoing challenges. And these are common themes throughout surgical data science and throughout machine learning, with the goal of improving patient outcomes in interventional healthcare. The first challenge is that errors are very costly. So in an interventional healthcare situation, if we provide information to the surgeon that is wrong or misleading, this can have severe impact on patient outcomes. The second challenge is that we have to be accountable. So it's not simply enough to recommend a course of action or provide a particular piece of information to a surgeon. We need to provide a reason why we recommended this action or why we provided this particular type of information. There's considerable heterogeneity in patients, their anatomy, and disease. Almost by definition, disease or pathology is heterogeneous. While we can, to some extent, model the distribution of disease and patients and anatomy, there is significant heterogeneity, and so it's very difficult to model these distributions without knowing the entire population or sampling a very large proportion of the population. And the final challenge is these things that we're doing are not in a vacuum. We need our computers or our machines to collaborate with clinicians. It's not simply enough to provide the best possible guidance. We need to provide the guidance in a way that is helpful to clinicians, again, to optimize these patient outcomes. And so while there are ongoing challenges, from my perspective, there's sort of one common theme which at least partially addresses all of these challenges. And that is integrating domain knowledge into our data-driven approaches. So this is what our main avenues of ongoing work are. How do we integrate this domain knowledge into our data-driven approaches in order to better address improving patient outcomes? So with that, I will conclude this presentation. Of course, this work is not done in a vacuum. It's very interdisciplinary. So I've had the privilege of working with many colleagues at various different institutions, both academic colleagues and clinical colleagues, who have all contributed substantially to this work. So I want to thank them and acknowledge their contributions. Otherwise, thank you for listening, and I'm happy to chat more or take any questions.
Okay, thank you very much, Dr. Holden. And now we can take questions. On the bottom of your window, there's a Q&A button. You click on it and you type your question and I will read your question. So we can wait a couple of minutes. So I can ask a question for now while we wait for to see if we will have a question. So in terms of software environment for your research, what's the best environment for you, like in terms of tools?
So the primary software environment we work in is a medical imaging platform called 3D Slicer. And so this is a medical image computing and image visualization platform. And so one of the things that we've done in the course of our work is we have built, for the case of computer-assisted training, we've built an open source platform on top of this 3D Slicer environment. And so it's called PERC Tutor. It is intended to facilitate the rapid prototyping of computer-assisted training applications. And so it allows us to do really simply things like data visualization, and it integrates some of these methods for skills assessment, context awareness, and automatic feedback that I had talked about earlier in this presentation. And so really these platforms are community projects where various researchers and labs, as well as various companies, have contributed to these open source efforts within the surgical data science and computer-assisted surgery communities.
Okay, and for students who would be interested to work with you, projects or graduate studies, what type of profile should they have ideally? Like do they need to have, in addition to background in computer science, a background in the field of medical computing or medical science?
Yeah, that's a really good question. So this work is very interdisciplinary. So this involves skills. So we require skill sets from multiple different perspectives. So from the perspective of analyzing the data and developing models, a computer science background is appropriate. But we also frequently work with medical students who can provide some of that medical domain knowledge and perform and do things like data annotation. We also work with engineering students who can facilitate deployment or development of platforms, so both the software and the hardware. So a lot of the sensors that we deploy in the operating room or in the simulation environment are quite sophisticated, and so require some perhaps development from mechanical engineering students or electrical engineering students. And in addition, of course, when we build these, we want to build software tools. And so from a software engineering perspective, we also look for students who have software engineering skills.
Mm-hmm. Okay, I think we don't have questions. And so in that case, I would thank you, Dr. Holden, for your talk. And I'll thank you for the audience for joining us today. The next Science Cafe will be in 1 week, same time. And it will be about gene processing, the splice of life. Thank you all for joining us, and have a wonderful rest of the day.
Thank you.